you. And thank you for the Operational Research Society for the opportunity to do this. Can you all hear me at the back? Yes. Okay, so I want to talk to you a bit about a scheme that we've introduced at Exeter called the Health Service Modelling Associate Scheme. But before I want to talk about the scheme itself, and Dan's going to help me do that, I'd like to just give a little bit of the background because I think that's important in understanding why we've done this. Here's a couple of quotes that we quite often use in OR health fora to talk about one of the main challenges, and this is a perennial ongoing issue in health services operations research. Too little, we are unable to reach any conclusions on the value of modelling in healthcare because the evidence of implementation was so scant. That was the conclusion coming out of a fairly comprehensive review done by David Fone and colleagues in Cardiff some time ago, and that's been an ongoing sentiment that's sort of echoed through the world of health services operations research, certainly for as long as I've been involved in it. And it's something that has motivated most of my research work, if you like, most of my research activities. And that's not because there isn't research being done. There's a lot of good research being done. Sally Brailsford, who many of you will know here, and myself and others were involved in a systematic review of operational research papers in the literature recently. And in order to do that, we had to sample the research literature. We couldn't keep taking the papers because they were arriving too quickly. This was an international survey. So it's not like there's no research happening in operations research. There's plenty of it. The problem is, if you look at these yellow bars on top, when we reviewed the papers, very few of them showed any evidence of implementation. And it's not like there isn't an appetite and a potential for the use of operations research in health services. I mean, we heard this morning from Simon Weldon that there's plenty of ways in which operational research can be applied in the health service, and certainly a demand for it to be used. So yeah, there's an appetite in the health service, and there's certainly lots of supply. So what is the problem? The problems, as always, or very often, is that the transfer of knowledge, the transfer of research across from the research world to the health services world is very small. The bandwidth is extremely narrow. And if you like, what's motivating most of my research and our team in Exeter, as well as many other teams in the UK, is to try and, excusing the clunky graphics, if you like, expand that pipeline between health services and research, and between research and the health services. And that's particularly relevant in operational research, I feel. And maybe we can do one more thing. We can actually bring those worlds together. Maybe that's an even better solution. So that is, if you like, the background to what motivates us establishing the Health Service Modelling Associate Programme in Exeter. And it was also the motivation for something we established in 2003-2004, which is the Modelling and Simulation Healthcare Network, which was initiated on the back of an Operations Research Society Special Interest Group meeting that happened in 2003. So MASHNet and the Operations Research Society have been very closely related, and we're very grateful for the support that the OR Society has given us for that national network through the many years it's been around. But then when the CLAHRC, I don't know how many people know about the CLAHRC, this is an initiative funded by the health services to bring the research worlds and the health service world more closely aligned. When they were established, that gave us an enormous opportunity to actually do the job of bringing the research into the real world of healthcare. And in PenCHORD, and that's the PenCHORD team, and I should stress this presentation's on behalf of the whole team, not just the two of us here, that the PenCHORD team always starts with the issues in the health service. That's our starting point, our point of departure for our work that we do. And a key aspect of what we do is not just providing solutions, not just giving people fish and feeding them for a day, to use that well-known expression, but actually aiming to build capacity in the health service itself, so in order to get them to use these tools and techniques in-house. So to teach them to fish, and if you like, feed them for a lifetime. And as part of that, we've developed a number of capacity building initiatives within PenCHORD, working across the southwest region at this stage. And we started with some modular program work, some seminars, and we were gratified to see that by and large, 95% of the participants at those events were from the health service, so there was a lot of interest there. But we were always keen, and we had it as a kind of aspiration for a long time, to do something a bit more ambitious, which was the Health Service Modelling Associates Programme. And that was the idea of actually seconding people out of the health service to work with us on a day-a-week release basis, to teach them some of these skills and to work with them on a problem that was of close relevance to the organisation they worked with. And we spent quite a bit, I just wanted to stress, we spent quite a bit of time sort of consulting with key people, including going to see chief execs at hospitals. We wanted to know that they would be willing to let go of one of their employees, one of their staff members, for a day a week to do this. And we found that they were really keen, and some of them were saying, can we have 2, can we have 3? Well, no, they couldn't, because we didn't have the capacity to do that, but there was certainly the appetite to do that and the willingness to support it. And also through that consultation process, and Dan will say a little bit more about this in a minute, one of the key things that came out was the need for the person working in the health service, whether they were a service improvement manager or an analytics person who was going to be the health service modelling associate, to be closely sort of overseen, if you like, by somebody more senior in the organisation, so that they weren't just sitting in a corner doing their piece of work without it being, if you like, knitted in to the organisational processes and represented on the boards and so on. So that was quite an important part of the workup. The other thing we did was we got the kind agreement is Mark Elder here? No. We got the agreement of Simulate. I think we got some Simulate people here. They kindly offered to support the programme through the use of the software, which gave the programme a coherence, if you like, because all of the HSMAs we were teaching on one piece of software, as you know, in terms of what they were learning, and we could keep that sort of learning set mentality together, so they could stay as a group and support each other from the different trusts. The other thing, just finally on this bit, is that from the outset, as this was a pilot, we were trying this out. We weren't aware of anybody having done this before. We thought it would be very important to have some kind of evaluation of how the programme would work, so that we can, when we'd finished, we could step back and look at, you know, what worked, what hadn't, and how we might remodel it for future phases of the programme. So we got an external evaluation project done that was quite an extensive piece of work in itself, and we'll mention some of those findings later on. But at this point, I just wanted to hand over to my colleague Dan, who was largely in charge of managing the programme, so he's got a lot to say about what we actually did with the HSMA.
Thanks very much, Martin. Hopefully that's given you a bit of a flavour about some of the context for why we wanted to set this up. So just to go into a bit more detail about this. The HSMA programme, essentially, we're taking selected people from the health service, largely analysts, although some service improvement leads, other roles in there as well. They're released from their normal duties for a day a week for a year in order to work on an advanced modelling simulation project for something that's really important for their organisation, for something that has executive backing. It's a pressing problem and they need help, but actually getting them to do that work themselves. And it's a way of trying to integrate operational research into the health service, which is not integrated at the moment. So we would provide training to use some advanced modelling software. Most of them used the Simulate software, as Martin explained. Others were doing some geographic modelling. And each HSMA would be supported by a member of the PenCHORD team, who would be their mentor, and essentially was there to guide them through the modelling process. And I'll talk a little bit more about that in a moment. As Martin said, they also had a second person who was a workplace supervisor. This is someone senior within their organisation who was there to open the right doors, make sure that the meetings took place with the right people, the facilitating getting the data, to make sure these projects actually got implemented and didn't just sit on a shelf, and that this person in the corner didn't become this odd person that does this weird thing that nobody really understands once a week. Importantly to the programme as well, we had a learning set. So all of the HSMAs got together in the same room once a month to talk. And anybody that's worked with the NHS will know that that's quite an achievement in itself. Just getting people from different organisations to share ideas, share these common challenges and potential solutions was really, really eye-opening, and we'll talk a little bit more about that in a moment. Ultimately, what we're trying to do with this programme is to get champions of operational research within the health service. We're trying to raise the awareness of what operational research is within the health service and actually make this a normal thing that's done. Because at the moment, a lot of people in the health service, because they have no experience of other methods, are making real decisions based on really bad evidence, or no evidence at all in a lot of cases. So actually getting this knitted in as a normal part of the culture is really important. So I mentioned the mentoring relationship. So essentially what we wanted to make clear right from the start was that we weren't a tech support desk. We weren't about somebody getting on the phone to us saying, I'm trying to do this and simulate, how do we do it? We guided them to self-learning for that and to simulate its own help. That we had ways of sort of teaching them certain aspects in Simulate. But ultimately, we were there to talk about the modelling process, because the modelling is so much more than just building a simulation model. It's getting them to think about structuring their problem, how they engage with their stakeholders and really understand the problem, how they translate that into a conceptual model and then move through to a formal model, and how you get sort of feedback from your stakeholders and how you might go about presenting that solution. And that was really important to convey right from the start of the programme. In terms of training, we had various training that we offered to the HSMAs. Part of this was through the training programme that Martin mentioned that we set up back in 2013. So looking at introduction to modelling, what is modelling and what can it do? Looking at geographic modelling problems, structuring problems using soft OR methods to try and unpick and better structure your problems, come out with focused questions. We also offered them a 2-day residential Simulate training, as well as Simulate offering online training as well as a masterclass as well. As Martin said, there was a evaluation of the programme that was going on within the CLAHRC but external to the PenCHORD team that was there to really, help us understand what worked well, what didn't, so we could refine the programme for future years, but also to try and understand what makes a programme like this work, and how can we try and achieve our aim of getting OR routinely done in the health service. So the learning set meetings, where we brought these HSMAs together once a month, they'd come, they'd talk about what their progress was on the projects, any challenges they'd encountered, any other issues, and just try and share some ideas. And we'd have the PenCHORD team who would facilitate that discussion, but ultimately it was a discussion. It was just getting people to talk. And the number of times, we had one particular learning set meeting where there was a guy from Devon Partnership Trust and a guy from one of the acute hospitals, and one of them had an issue that he encountered for many years, and in mentioning this to the person from the acute trust, this problem he'd had for 3 to 4 years got solved in 10 seconds because they'd spoken to each other. And it's an amazing thing to behold, but really there was so much value in just getting people to talk. So because of that, the evaluation actually demonstrated, and Martin will talk a little bit more about this at the end, there was increased collaboration between NHS organisations. It was breaking them out of this silo mentality that they get stuck into. There was increased collaboration with us in academia and embracing us and research more generally. There was increased confidence in modelling and what modelling can do. And beautifully, the HSMAs managed to get very confident in actually presenting their work. A lot of them were not confident at all. They didn't have I think they had the skills to be able to talk to people about what they'd done. Very often sort of sat in the corner and sort of quietly getting on with their day job. By the end, they were presenting to large-scale seminars very confidently about this work that they had done over the last year. So I'm not going to spend too long on this. I just want to whiz through the 6 different projects in terms of some of the key bits of impact that came out from it. Each of the pictures that come up, that represents the HSMA that was involved. So this is a guy called Nick Harrison from North Devon Hospital. He was looking to model their A&E. On the back of that, they improved the staffing shifts at their A&E. It became a standard tool for answering all sorts of what-if questions about their A&E. He then went off and set up meetings with executives, chief executive, other executives in Cornwall, Exeter and Somerset to share that learning. They then fed all that into the Sustainability and Transformation Plan that we were talking about this morning. And then he led a Health Foundation bid, to actually try and get OR done region-wide. We had a guy called Joe Turner. He was from Royal Cornwall Hospital. They were looking at whether they could put in an acute frailty unit and what they'd need to do in order to run that practically. The plan originally was they were going to do this and see what happened. He built a model and it turned out they couldn't do it. They didn't have the resources to be able to do it. So it stopped them making a really bad decision. On the back of that, he was asked by the executives to undertake 2 further projects, and he got promoted. And he cited particularly his increased exposure, increased visibility in this programme as being a key reason for that. We had a guy from Devon Partnership Trust, the Mental Health Trust, looking at the urgent care pathway for mental health patients. The model showed they had too few beds and a lot more variability than they thought. These guys were planning based on averages before. That's all they had. And there was huge amounts of variability in the system. So they used it to explore practical what-ifs. They invested in the Simulate software, and they wrote OR into this guy's job role. So it's now embedded in that trust. A guy from Derriford, looking at discharge patterns across the week, managed to, just by talking to people and process mapping, managed to make some real changes to policy there. I'm conscious we're running low on time, so if you want to find out more about some of the specifics on this, then there's more information on the website, which I will show you in a moment. Another guy there got promoted on the back of this as well. There were some challenges that were identified through the evaluation, and again, we can talk to you a bit more about that if you'd like. But what I do want to do is just show you a quick video so you can hear them themselves.
So the HSMA programme stands for the Health Service Modelling Associates programme. And the programme is all about supporting people within the health service to be able to build and use simulation models themselves. So the sort of stuff that we do on a daily basis, building models, building complex models for organisations to help them understand the potential impact of changes, to actually get people in the health service doing this stuff themselves.
The way it teaches you to think about problem solving, for me, was one of the most useful things I took from it. I view it almost as a tool that I now have in my toolkit that I can use in other aspects of my work that I didn't have before. And I didn't really go into the project expecting that, whereas I came away with a sort of a new methodology of approaching problem solving that I'm going to use in lots of different, and have already used in lots of different projects already.
We've seen the trusts that have been involved in the programme really run with this idea of having modelling capacity within their own organisations. And we were delighted to see them get so enthusiastic about the potential for modelling to help, and to get the HSMAs engaged in lots and lots of additional projects, working on other things, and getting real visibility from the executives involved in those organisations.
We're going to be considering modelling a lot more as a result of this programme. Senior managers and certain decision makers within this organisation have seen where modelling can be beneficial. It's a bit of a testament, I guess, to the team and to the programme, because it's kind of exposed what modelling can do when you're trying to implement change in an organisation.
In terms of a legacy for the organisation, I think we've really been able to demonstrate to our top team, our execs, that operational modelling has a variety of different impacts for the organisation and can actually answer some questions in a real time, but in a hypothetical way. So it's answering those what-if questions in a way that's accessible for people.
We want to recruit more HSMAs over the years. We want more people to become involved in the programme and to go on to pass on their knowledge to colleagues within the organisation until this does become a normal thing that's done in the health service and it can really make a difference and really affect change in the health service.
Thank you. Last thing I would just say, if you do want to find out more about this, there's a website, health-modelling.org. Lots of information, lots more videos on there from the HSMAs about their individual projects as well. So I do encourage you to check that out if you are interested.
Yeah, thanks, Dan. So very short of time, so I'm just going to step through that. Just to say, we did get a lot of output from the evaluation, and we're using all these kind of points coming through from that report to take on board for our next generation of the programme. I'd like to just talk about some of what we see as some of the major benefits of this, because I think it's not just one thing, there's lots of things that are impactful in this work that's been done. First thing is, we've done 6 separate OR studies done by people in the organisations that have had generally important impact to the organisations themselves. Some including several £100,000 investment in A&E, for example, have been informed by these models that the Health Modelling Associates have done themselves, and some of the other things that Dan said. So there's a number of projects built by the health service organisations themselves that have had an impact. But that's really, in a way, a byproduct of what we were trying to achieve. One of the other things that's important in this is that the NHS organisations had ownership of those models. It wasn't some external agency sort of imposing these models on them and having to explain them. It was done in-house, and they were therefore understood at a much deeper level within that organisation and accepted at that level. I think we generally, as Dan said, we've improved the profile of operations research. It's now becoming a question that gets asked in boardrooms. Could we use a model to address this question that we've got in the board, for example? So it's raised that profile, and that's been a major impact. Perhaps one of the most important impacts is in developing the skills and having people now working in improvement roles, in analytical roles, who begin to know how to adapt some of these solutions, use some of these OR methods to address real problems in their organisations. It's also been very, very good at strengthening links both between us and other research organisations in the health service, and also within the collaborating organisations between the hospitals, for example, where the learning set of health service modelling associates could help each other. I think that's one of the most gratifying aspects of the programme. And those skills within the health service modelling associates are being passed down to other members of their teams within those hospitals and those organisations. So it's the propagation of those skills, not just what we taught the HSMAs themselves. And we're keen to support that on an ongoing basis, and I'll say a little bit more about that in a minute. And finally, we've set up a template in a way for a way of working, a mode of engagement, if you like, between the health services and the research world. And I think that's a template that we might want to look at extending in due course. And this is my final slide, you'll be pleased to know. What are we doing next? Just to let you know what's happening. Obviously, we're going to run this again. It's been a great success. We're going to look at remodelling it. We might expand the suite of tools that we offer to the Health Service Modelling Associates. We're working with the South West Academic Health Science Network, and we're going to be collaborating on a regional initiative together for the next generation of the programme. And that will start sometime between November and January coming. On a national scale, we're working with a number of organisations, including the Operations Research Society, to look at ways in which we can investigate and use this, if you like, as an illustrative example of how research and NHS worlds can be more closely knitted together. And there's a number of things happening, including a recent Health Foundation initiative that is taking some of these ideas forward. That's probably enough for now, is it?
Okay. Thank you, Martin. Thank you, Dan.